You're free to make your own healthcare decision, and you're free to play Russian roulette or not. Do it. But there's enough good source. Would you not trust the American Heart Association, the National Lipid Association, the Endocrine Society, people who really know about lipids? We've got 100 years of research on lipids. It's not like we discovered them last week and we're making all this stuff up. This is solid as science can be. Now we're getting a hell of a lot smarter with our genetics as far as helping us even better ascertain risks.
Welcome to the Everyday Epigenetics Raw, Real, Relatable podcast. I'm your host, Susan Robbins, epigenetic human performance coach. This is where we discuss all things lifestyle, environment, food, exercise, work, mind, and social interaction as they pertain to epigenetic expression in a way that's relatable to everyone. So if you're ready to start viewing you as an individual, take control of your life and health, and get results, buckle up, here we go. Welcome to the Everyday Epigenetics Raw, Real, Relatable podcast. I'm your host, Susan Robbins. This is the place where we talk about everything lifestyle and environment and how it relates to our genetic expression. I am super excited today to have this guest on with me. We are doing a two-part series on two of the most seeing more prevalent, and that's why I wanted him to come on, because I am seeing this in my practice. Two genetically driven lipid disorders. Next week will be Lp(a), and today is going to be something that had been termed for many years, and when I started doing genetics, it was called sitosterolemia. And it's about the hyperabsorption of plant sterols. And my guest is going to explain all of this today in terms that you will understand. I have seen him, listened to him, and he is fantastic in helping the layperson understand, because it's a pretty deep topic, and who knows how long we're going to go here, so buckle in. But the term that is being used prominently now, or should be used, is actually called phytosterolemia. So I'm going to, this resume of this guest is so incredibly long. I'm going to let him introduce himself. His name is Dr. Tom Dayspring, fellow Jerseyite, and I am just super grateful to have you on my program this week and then next week, Dr. Dayspring. Tell everybody who you are, because it is wow.
I don't know about that, but thanks, Susan, for giving me an opportunity to spin lipids, which is my favorite topic. And I am a Jersey boy. The first 65 years of my life were in northeastern New Jersey. And the last 14 years, I've relocated to the central Virginia area and the Old Dominion, as we call it down here. Mm-hmm. It's a nicer place to slow down as you're winding down your career. But my career doesn't seem to be winding down for whatever reason. So I'm a internist by training, and practiced for 37 years in the state of New Jersey before locating to Virginia. What got me down here was an opportunity to become a full-time advisor to biomarker laboratories. But anyway, after internal medicine, and I like to joke, I trained in the dark ages. My med school was 68 to 72, residency through 75. But at that time, like it is now, heart disease is the leading killer, but it was a far bigger killer back then because there was zero we could do to really even diagnose them before they had an event, and for sure to treat them as far as risk factors. We had a little bit of blood pressure control, nothing with lipids. I was just a good hard working internist, very much of a preventative mindset. And somewhere around the 1980s, it became pretty obvious as finally some trials started to come in that lipids were an important part of a metabolic disease, certainly atherosclerosis. So I figured I better start studying this stuff. And I'm a self-taught guy, and I studied. A little bit later, I had an opportunity to go out and lecture a little bit locally, and to my shock, because I was always a shy guy, to be honest with you, I never wanted to go in front of a room. But I had the opportunity. As far as lipids were concerned, I knew it enough, and I got a lecture, and boom, before you know it, by the time I said no more lectures, 4,000 in all 50 states and several countries. Not only am I an internist, I like to brag on what they call an FACP, Fellow of the American College of Physicians. That's a higher level internist. You have to have published or done teaching or something that elevates you above the run-of-the-mill internist. Then, when finally lipidology became a real specialty, I was in the first group that passed the lipid certification examination. And I was in the first group that achieved a title called Fellow of the National Lipid Association. And that's just you have to prove even higher that you're into lipids via publications, teaching, whatever. And just about 10 days ago, the National Lipid Association honored me by elevating to me what they call a Master of the National Lipid Association, MNLA,
Wow.
and among the thousands of lipidologists, there are only 25 of them. So this was a distinct honor that I have achieved. You can't go any higher. There's no more
Wow.
distinction they can put on you as a lipidologist. I'll wind this up, and Susan knows, I think the biggest bragging point of my career, and it happened in just around the turn of the millennium. I was the first physician in the United States to be certified in both lipidology, clinical lipidology, but also menopausal medicine by the what was then called the North American Menopause Society. Now it's simply the Menopause Society. So I've been very much into having a soft spot in my heart for women who uh, and I think it's still today, but absolutely in my dark ages, I got terrible cardiovascular care. And I wanted to correct that a little bit. So I delved into that world big time. So listen, I've done a lot in the lipid world.
Cool.
Interesting, Susan mentioned phytosterolemia in the I've actually written a book chapter on that disorder, so I'm pretty well qualified, I think, to discuss it. So I'm all yours, Susan.
I love it. And when I interviewed Dr. Gil Carvalho a few weeks ago, I asked him because I've been trying to find someone to speak on this topic for the 2 years I've been doing this podcast because I've never felt comfortable enough doing it on my own because it's such a complicated topic. And so I even emailed the Sitosterolemia Foundation and said, can you point me towards someone that can help? Never heard anything back. So I've been struggling. And Gil said, I asked him and I said, can you speak on it? And he said, I can, but I would rather connect you with the man that can absolutely speak on this. And he just gave you such props as to being able to speak on this. And then he turned me to the podcast or the shows you had done on his show, and I just thought this is absolutely a perfect fit, exactly what I'm looking for. And so I was just super grateful and excited to get you on here and talk about this. I've been doing genetic testing for over 7 years, and my array is one of the very few that test for these specific genes. They are the ABCG8 and the ABCG5 genes. Now, I looked because the group that I work with now, there's always new ones coming in, and I just saw ABCG5 go away on the last one, and so I have to contact and say, wait, where's ABCG5? But ABCG8 does not ever go anywhere. That is staying. And again, I've looked at so many other DNA reports, and I've never seen the ABCG8s tested. And this is when I had my first DNA training through Apeiron Zoe, and they have the Apeiron Center for Human Performance in Austin, Texas. And this is how I found out about this. And they said that it's supposed to be about 8% of the population. And I want you to correct me if things have changed or if it's wrong. But they said it was about 8% of the population. However, in their clinic, they were seeing about 15%. And I thought, I'm never going to see this. I started seeing it coming up where people, as you term it, homozygous total loss of function of these genes, or LOF for loss of function. So we'll look for having both variants in these genes. And I started seeing this coming up, and I had 3 people one week, a couple people another week, and I'm going, whoa, this is kind of crazy. And then I currently have 4 people with this right now. 2 of them are sisters. The one sister started, the other one just came on, and I just did her sister's DNA yesterday, and there it is again. So I said, we need to test and see if this is actually expressing, because as we know with DNA, it's about the expression of these genes.
But when you're homozygous, it is very high risk. And it's high risk, again, correct me, for a cardiovascular event. A lot of times I'll hear that they have a family member, not always, but a lot of times I'll hear they've had a family member, typically the dad or mom died of a cardiovascular event at a pretty early age, 40s, 50s, a lot of the time. Cholesterol just picks up usually around, I've had it in a male in his 20s. It was 26, but I see it in their 30s. It'll start up. Sometimes they don't even, it's just really not tagged by the physician, other than we'll just put you on a statin or we'll just keep an eye on it. And because a lot of times that can be a first symptom. But I'm going to have you speak on this more. I just wanted to give an intro from where I'm coming from and why I wanted to have you on here, because doing genetics, I'm seeing this. And I'll bring up more things as I think of it and as you go, that are on my mind as well around this. But let's delve in and talk about what is phytosterolemia, what are plant sterols, and how do they build up? How do these genetics play this major part?
All right, this is going to get a little bit ugly because we have to start with a little basic biochemistry, and I'll spell it out. There are many organic molecules, carbon, hydrogen, oxygen, whatever. That's what an organic molecule is. But and there are several subgroups of what type of organic molecules there are. And the group that we're going to talk about today is called sterols, Sterols. Now, I think everybody knows one sterol. It's called cholesterol. Cholesterol is chole is bile, sterol is in that class of molecules. If we could draw here, sterols have four rings that are stuck together, and then they have a little tail. And on the first ring, sticking out from the left side, is an oxygen hydroxy group. And that makes the sterol, the hydroxy side, remember water is H2O. So there's an OH on the sterol. So that side of the sterol is water soluble. Now the other side that has the tail coming off the fourth ring, that's all carbon atoms. So that's pure lipids. That's hydrophobic. So that side of the sterol molecule is not miscible in water. And that gives sterols incredible properties where they have to align where one part is interfacing with water and the other part is sticking into the lipid part of a cell or a cell membrane. And that's why sterols are in cell membranes. That's what's cholesterol's primary function. And what will show you, if you're not a plant, a phytosterol is the last thing you want in your cell membrane, because then you're going to have a not properly functioning cell membranes, and cell membranes regulate almost everything that's as far as the health of a given cell, what gets in, what gets out. So the predominant sterol in the animal kingdom is, of course, cholesterol. So we now can divide sterols by zoosterols, a sterol you might find in a creature that's in the animal kingdom. But last time I looked, plants all have cell membranes too. But plants, with rare exception, do not have the ability to synthesize cholesterol. Animals and humans do. So obviously, they have to have sterols in their cell membranes, but they're a little bit different than cholesterol. And hence, they're not in the animal kingdom. We would call them phytosterols. And there are many of them. Unlike the animal sterol, there's one cholesterol. In the plant kingdom, there are at least 50 different types of phytosterols that are in different types of plants or so. Now, who cares? Except we as humans eat plants, so you are swallowing phytosterols. So just keep that in mind before I go any further on that. If we really want to go into this, sterols have two categories: cholesterol and everything else that is not cholesterol. Originally, it was just called non-cholesterol sterol because it's not cholesterol. But now we know you can break up non-cholesterol into different groups. And one of the biggest groups are the phytosterols I just mentioned. They're found in plants. But remember, when a plant synthesizes phytosterols, or when humans synthesizes cholesterol, it's over 30 steps to go from a 3 or a 5 carbon molecule to a 27 molecule sterol or more in the carbon groups in a phytosterol. Every intermediate on your cholesterol synthesis pathway is also a non-cholesterol sterol. There are 15 or 20 of them, desmosterol, etosterol, and lenosterol, and they're not cholesterol, but they're not exactly phytosterols, so they're a different group of non-cholesterol sterols. But anyway, why are the phytosterols so important? Because I think it was around 1975 that two little girls, twins, showed up in a clinician or some lipid clinic, and these kids had xanthomas, they had anemias, there was a strong family history of heart disease, they had kidney disease, and they said, what the heck is going on with these kids? So they investigated, and by that time, there was laboratory equipment that could do very sophisticated sterol testing. So most of the labs are checking for cholesterol. There are no labs, unless somebody specifically orders them, checking for non-cholesterol sterols. So, but they did. This was these lipid clinic did research, and the most predominant sterol they found in these two kids was sitosterol. Now, I'm going to smack Susan a little bit. She mispronounced this sitosterol. I'm going to tell you how to pronounce it. So this molecule that was discovered in these kids is a phytosterol because plants make it, humans do not. It's sitosterol, S-I-T-O-sterol. There's no ER in there, sitosterol. So, but if you have elevated sitosterol in your bloodstream, if you have too much cholesterol, it's hypercholesterolemia. So if you have too much sitosterol in your blood, it's sitosterolemia. So they labeled the disorder that these kids had as sitosterolemia. Now, they checked several other phytosterols, and they were all elevated, but for some reason, sitosterol, because it's the most common plant sterol, that was the highest concentration. So they labeled this disease sitosterolemia. But now we're 50 years later, and about a decade ago, we realized it's not fair to blame sitosterol. What about the other 42 phytosterols that are also elevated in these people? So the name changed to phytosterolemia because there's a lot of sterols at play. It's not only sitosterol. The second most frequent is, and this is important because you can test for it, is campesterol, C-A-M-P-E-S-T-E-R-O-L. Now, there are many others, but if you want to test for this concentration of these substances, those are the two that laboratories are likely to do if you ask for plasma sterols doing that. So it's a bunch of non-cholesterol sterols, they're phytosterols. We now know that even a better term, because they have so many sterols out of whack, is change phytosterolemia to xenosterolemia, X-E-N-O. Xeno in Greek means it's other. So other sterolemia, that's the true name of this disease. So call it what you want. But now remember, so if I say phytosterolemia, that just means I've measured some phytosterols in your bloodstream and they're increased. So you have phytosterolemia. Now, there are a bunch of disorders. There's one disorder that causes this, but there are different levels of phytosterolemia. Now, what was described in these kids, sitosterolemia, that is a phytosterolemia. Now I have to explain how do you get this or so. So now we're back to how the gut absorbs cholesterol into your body and how does it make its way into the bloodstream where it can be measured and where it can invade your cells and cause pathological harm. So look, we eat a little bit of cholesterol, we eat veggies, and you have a gut pool of sterols that are ready for absorption. We got to give you a little sidetrack here. With respect to cholesterol, if I could go in anybody's intestine and grab a pool of sterols, especially cholesterol, and I could interview them and say, hey, Mr. Cholesterol, Miss Cholesterol, where did you come from? And how many would say, I got swallowed because this person ate something that had me in it? And that would be about 30% of the cholesterol that's in your gut. So that means 70% of the rest of the cholesterol in your gut didn't come through your mouth. It came from your liver through the bile duct into your gut. And the liver was trying to get rid of too much cholesterol in your body. That's one of the body's defenses against letting cholesterol build up too much where it's toxic. So most of the cholesterol that any human is going to absorb was produced, synthesized, endogenously in the cells of your body. They got trafficked to the liver. The liver sent them to the gut on the hopes they would be excreted in the feces. But the gut absorbs about 55% of the cholesterol if it's working normally. Now, what is it in the enterocyte is the cell that lines the gut lining. So anything that gets absorbed goes into an enterocyte, and then the enterocyte decides what gets into our bloodstream. So the enterocyte has a specific sterol receptor that sticks into the gut lumen and recognizes sterols. It's called the Niemann-Pick C1 like 1 protein, NPC 1L1. And there's a gene for that if you want to test it or so. The Niemann-Pick C1 like 1 has some sterol sensing domains. They stick into the gut lumen, and they are engineered to recognize cholesterol. So that is the sterol that should be absorbed in a normal human being. But look, the sensors don't work 100% perfect. So they actually pull in some phytosterols also. Sitosterol, campesterol, stigmasterol, the list is long. So they get pulled into the enterocyte like cholesterol does. Now, it pulls in more cholesterol molecules than it pulls in phytosterol molecules, but hey, they're in the enterocyte, but they're not in your bloodstream yet. The enterocyte has the power to say, what the heck did that Niemann-Pick absorb? Hey, okay, you're cholesterol. We do need cholesterol because this is a human. We're going to let some of you get in. But you phytosterols, this is not a plant. We don't want you here. So now we're going to get to a word Susan already mentioned. Also, we have a receptor that can be expressed in the enterocyte, manufactured and expressed, called ATP binding cassette transporter G5 and G8. ATP is energy because this is a transporter that needs energy to pump things. Like the Niemann-Pick was a sterol influx transporter, the ABCG5, G8 are sterol export transporters. So if you overabsorb phytosterols, there are sensors there that tell your DNA and the enterocyte genes produce ABCG5 and G8. So they produce both of these now, and they join together. It's like a marriage. That's called the heterodimer. Niemann-Pick is just one. It works all by itself. But the ABCG5 and G8, there's one G5 and there's one G8, and they stick together. And then they migrate to the surface of the enterocyte that interacts with the gut lumen. And what they do are they are sterol efflux transporters. So they grab sterols and say, you're not getting in. We're throwing you right back to the gut lumen, and hopefully you'll be excreted in the stool. So if you have perfectly functioning Niemann-Pick to pull things in and perfectly functioning G5, G8 to evict things if they were overabsorbed, you are going to have perfect sterol absorption, and there will be no phytosterols in your bloodstream, other than some trivial amount. There's always a few that get in. So, but what if you have, and we're talking to a woman here who knows a lot about genetics, what if you have what Susan called loss of function, meaning your Niemann-Pick works, but it ain't working as good as it should. The ABCG5s are working, but they're not working as good as they should. If you have a loss of function of the Niemann-Pick, you're going to be a hypoabsorber of sterols. Interestingly, when they first discovered that in the early 2000s, they said these people who have the loss of function of the Niemann-Pick have very low cholesterol levels in their bloodstream, and they have a lot less heart attacks as they get older and older. It's a genetic thing. It's there from the day you're born to the day you die. So if you are a hypoabsorber of cholesterol, obviously you're going to have less cholesterol inside your body, and you're going to have far less in your artery walls, so less atherosclerosis. This is what led to, hey, if we could invent a cholesterol absorption blocker, it would be great at reducing heart attacks. And that's where ezetimibe came into play. It was the first and still the only cholesterol absorption blocker that we have. It interferes with that Niemann-Pick C1-like protein, so you absorb significantly less cholesterol than you should, and that's good. All right, but that's only half of our sterols going to get into your body. It's the Niemann-Pick. But what if you had your Niemann-Pick pulled them in and you got phytosterols and cholesterol there? Now you depend on the G5, G8 heterodimer to recognize both excess cholesterol, but any phytosterol that is there and evict them out. And this is so cool how evolution engineers these things. The Niemann pick is engineered to recognize cholesterol, far less engineered to recognize phytosterols. That's why phytosterols don't get in most people for the most part because the Niemann pick doesn't bind to them. But once they're in, it's just the opposite. The ABCG5 G8 is now going to evict any sterol that doesn't belong there. Its highest priority are phytosterols, xenosterols, and less affinity for cholesterol, although it still has cholesterol affinity. So any phytosterols that got in, if your G5 and G8 are functioning, are going to get punted right back out to the gut lumen. Any excess cholesterol you absorbed will be punted right back to the gut lumen. But phytosterols are first play for the G5, G8 because evolution knows we never want a plant sterol to be in any human cell membranes. So if all goes well, now what does the enterocyte do with the cholesterol it has absorbed and a few phytosterols that ABCG5, G8 missed? It now puts them into something that's going to traffic them into your bloodstream. And there's two choices for the intestine to do that. Most of it gets put in an intestinally produced giant lipoprotein, which is a lipid droplet wrapped with a protein called the chylomicron. That's the big fat thing. And what the chylomicron does, it's a protein on called ApoB48, but it's filled with cholesterol, and cholesterol that's been esterified to a fatty acid called cholesterol ester. Now, if there are any phytosterols, the esterification enzymes doesn't recognize them, so they get put in the surface of a chylomicron because remember, they're sterols. They have a hydroxy group. They can interface with water. Free cholesterol is on the surface of the chylomicron also. So that's one way the sterols get in. What's the other component of a chylomicron? All the fatty acids you absorb got remanufactured in the enterocytes to triglycerides, and that's a big fat triglyceride carrying particle. But it's carrying absorbed cholesterol and any absorbed phytosterols that didn't get evicted. They take a circuitous route, go through the lymphatic system and then into the bloodstream in your neck. There's something called the thoracic duct. Oh, wow. And all of a sudden, chylomicrons carrying absorbed cholesterol and phytosterols are now floating in your bloodstream. But the gut has one other way to get sterols in. The gut expresses another ABC transporter. It's called ATP binding cassette transporter, A1. And why A1? Because A1 is a plasma protein that is the peptide that's going to evolve into an HDL particle. And part of the places where ApoA1 in the bloodstream can acquire cholesterol is to bind to an enterocyte that at its plasma surface is expressing ABCA1. So your HDL particles can carry cholesterol on the surface. A little trick is if you see somebody with high LDL cholesterol and high HDL cholesterol, the odds are good they're a hyperabsorber of cholesterol. It's an old-time clinical lipidology trick. Not always, but it's a signal to you. Why is the HDL cholesterol elevated? There may well be a hyperabsorber of cholesterol. Okay.
Can I ask a quick question off of that? Piggyback off of that. So you'll hear people say that their physician will tell them, okay, but your HDL is great here, even though the LDL is also high. The HDL is high, so you're fine. We don't.
That is utter nonsense. That is malpractice to say that in the year 2026. We now know HDLs are a crucial part of the lipoprotein system, but what they do has zero to do with the amount of cholesterol they're carrying. HDLs are really the small ones that don't carry lipids, are full of protective proteins that travel here. They fight inflammation, they fight infections, they fight cancer. So they're a protein carrying. How much cholesterol is in them is irrelevant. There are people with high HDL cholesterol who get heart attacks. There are people with high HDL cholesterol who get dementia, who get osteoporosis. So there is no guarantee of anything because you have high HDL cholesterol that you're protected. Now, in general, you could say it's better to have higher HDL cholesterol than lower, But in an individual patient, you don't know. So you stop saying stupid things like that, that
Thank
the
you.
HDL is protecting you, because we have zero HDL functionality tests that are available to us. And measuring HDL cholesterol has left the practice of lipidology for the most part. And there's no, everybody thinks you got to raise HDL cholesterol. There has never, ever in the history of lipidology been a guideline that has given us an HDL-C goal of therapy. We now have several trials where certain therapeutics raise HDL cholesterol and they didn't reduce a single heart attack. Stop looking at HDL cholesterol and pontificating about what that means, because you have no clue what it means. Focus on the other lipoproteins. They carry ApoB, not ApoA1, your LDLs, your VLDLs. Those are the potential transporters of cholesterol into your artery wall. So anyway, back to the guts. HDLs, of course, now may carry some phytosterols if ABCG5, G8 didn't evict them, and so would chylomicrons. So if I tell the laboratory, I want to do a sterol analysis, and there's a bunch of sterols they might measure, but the two they're going to measure to say, does this person have normal absorption, hypoabsorption, or hypoabsorption, are going to be plasma sterols, because no human should have any significant amount of phytosterols in their blood. So now, true, even if I find a minuscule amount of phytosterols in your blood, you have some degree of phytosterolemia, but it's a minuscule, it's a non-pathological related elevation of those sterols. So when you get the test back, you have to know what's a high, low, or a mean. If you do find increased levels of phytosterols in the blood, if you have overabsorbed phytosterols, you have massively overabsorbed cholesterol, because the Niemann-Pick is pulling in far more cholesterol molecules than phytosterol molecules. So this is why when we measure phytosterols in the blood, its main purpose is to say this person has hyperabsorption of cholesterol. Earlier, I told you hypoabsorption of cholesterol, there's less heart attacks. Yes. Hyperabsorption of cholesterol, there are more heart attacks. This is why it might be important to know whether you're a hyper or a hypo or a normal absorber of cholesterol. Because if you come to me, say you're high LDL cholesterol, or a better test, high ApoB, they're the particles cholesterol, I would like to know, are you a hyperabsorber or a hypersynthesizer? For the simple reason, if I have to lower your LDL cholesterol or ApoB and you're at high enough risk that I want to use a drug, if you're a hyperabsorber, I want to block absorption. I want to prescribe ezetimibe to you. But if you're a hypersynthesizer, I want to prescribe a synthesis inhibitor, and that would be a statin or bempedoic acid. We have two of them nowadays. And it's so funny here. If you're a hyperabsorber of cholesterol, now the doctor who's not measuring these sterols and not doing genetic tests for ABCG5, G8, he's going to say, oh boy, your cholesterol is up. I'm going to give you a statin. Statins don't work very well if you're a hyper, because you're not correcting the defect. And listen to me now. If you inhibit synthesis with a statin, your gut, the body says, oh my God, we're running out of cholesterol. We're not making it. You actually absorb more. So statins in some people worsen cholesterol absorption. Now, look, the same is true of ezetimibe. Suppose LDL cholesterol is up. You're not doing steroids. You say, I know you don't want a statin. You read online they're terrible drugs. So I'm going to just give you ezetimibe instead. If you give ezetimibe to a hypersynthesizer of cholesterol, it doesn't work very well. And it actually, the body says, oh my God, we're not absorbing. They start synthesizing more cholesterol. So if you practice medicine 3.0 and you're really looking at these things, day one, if you feel I need a drug for this, you will pick the appropriate drug to give to that individual to lower their LDL cholesterol or ApoB. And there are certain lifestyle things you can do that would reduce absorption also. So back to those ABC. Go ahead.
I find this so fascinating. So I have a client who is the homozygous for all of the ABCG8s, yet all of her cholesterol is within range. It's under 200. The LDL is under 200.
Well, I'll get into that, right? Why? Because In the people who have what we call, and I'll better describe this in a moment, homozygous loss of function of either G5 or G8, they so massively overabsorb phytosterols that it shuts down cholesterol synthesis because the enzymes in the liver say, wait, there's sterols there. No, we better not make more cholesterol because we're drowning in phytosterols. So if you have decreased activity of HMG-CoA reductase, the main enzyme that synthesizes cholesterol, statins aren't going to work. So giving statin to somebody with phytosterolemia is a poor choice. You will make it worse. So, and this is sad and I'll tell you why. But anyway, so back to the ABCG5, G8. I want to explain this heterozygous, homozygous. So you have G5 and you have G8, and they work as a pair. Now, the typical hyperabsorber of cholesterol has partial loss of function of either G5 or G8. Now, there's ethnicities related to that. Asians have I believe they have the G5, and Caucasians have the G8. So Caucasian is likely to have loss of function of G8 and the other one G5. I could be wrong on that. I always confuse the two. But if you lived in China and you were doing this, you'd be more interested in one of the pair of the heterodimer. In the Caucasians, it's the other one. And so you could have a partial loss of function of either G5 or G8. That means that heterodimer is just partially broken. It's still evicting most of the phytosterols, but not all. So that person is going to have a moderate increase of phytosterols in their blood. Now, you would call them as phytosterolemia, but that is heterozygous loss of function, a far less serious disease than what I'm going to tell you now. Homozygous loss of function of either the G5 or G8, that means that dimer is broken. Any phytosterol that the Niemann-Pick absorbed is now going to be put in your chylomicron or your HDLs. Now, when we measure phytosterols in the blood, there are lipids. They don't circulate in the bloodstream by themselves. There's no free cholesterol in your bloodstream. There's no free triglycerides in your bloodstream. They're all components of a protein-wrapped transportation vehicle called the lipoprotein. So what the lab does is it pulls out HDLs or any of the ApoB families, and they dissolve the unilayer surface, the phospholipids and the sterols, and then they measure the sterols using mass spectrometry. So that's how, when you get a high cholesterol level or a high the lab is measuring the cholesterol that's in circulating lipoproteins, and it's also measuring phytosterols. Here's why this gets never diagnosed, because nobody's measuring phytosterol levels. Now, when your laboratory reports to you total cholesterol or LDL cholesterol or HDL cholesterol, that's a very crude assay. That cholesterol assay doesn't know the difference between cholesterol, sitosterol, campesterol, stigmasterol. So really, when you get LDL cholesterol, it's really LDL cholesterol plus LDL sitosterol plus LDL campesterol, blah, blah, blah. HDL cholesterol is HDL cholesterol plus HDL sitosterol. This is why you have to measure sitosterols in the bloodstream. Then they do a much more sophisticated chemical analysis that says, aha, all of these sterols are not cholesterol. There's too much of the other sterols. And the higher your level, you have some degree of phytosterolemia. So typically the levels are quite.
And I just want to interject here really quickly that I have clients ask their doctors about this and to test, and the amount of pushback we get, they're saying, I'm not testing that. You don't need to test that. But there is a test and I send them to, and I used to work with them, True Health Labs it's through Boston Heart Labs, and it's the cholesterol balance test. And it is to look at these sterols for root and see if you are hyper absorbing.
That's correct. So listen, I'm a doctor and I can smack other doctors around. And they tell patients you don't need this, is they have no clue what the patient is talking about. So a doctor's ego will not permit him to say, oh, I don't know that. Let me go read about it. No, they will just call the patient, oh, a dummy, stop going on the internet and finding these things. And that is sad. This is why one reason that in lipids, there's a lot of incompetent care. They just don't know this stuff. And that's sad, because we now are knowing partial loss of function of G5 and G8 is a common cause of hyperabsorption of cholesterol, which is a common aggravator of cholesterol levels in the blood. Many, many people who have familial hypercholesterolemia because they have other genetic defects, there's a lot of what we call compound heterozygosity. They also have G5, G8 defects on top of whatever other damn defect they have, and they have monster lipid levels in their blood. But if you didn't know that, you might not give them ezetimibe as part of their therapy. So this is why it's important. So to be a true homozygous loss of function of G5 or G8, by the way, there's only been two or three in the history of testing that they've ever found humans who were homozygous for both G5 and G8. It's
Yeah, I
one or
haven't
the
seen that
other.
yet.
Yeah.
Yeah.
So no. And listen, the homozygous loss of function, were taught that it's 1 in 1,000,000. We now know it's 1 in 200,000. So the average physician will never see it. So I suspect in your clinics you have marked hyperabsorption of cholesterol. You don't have true genetic. If you do, the way to prove it is not even a gene. You have to measure phytosterols, and if they're above 30 milligrams per liter, that is the criteria for true homozygous phytosterolemia. You will rarely see that.
Yeah, when I see that, when I do their DNA and I see that they are homozygous, especially in those ABCG8, I absolutely recommend. I say, here's the test to get. Some will say I want to talk to my doctor, but typically they'll order it from the True Health Labs. It's $159. Is it? And I say it could be the best $159 you've ever spent. Do it.
Yeah.
It's a take home kit. They send it to you. You find somewhere to get it drawn, send it back, and within 10 days. And that's what I always do. I always recommend it because I say the only way you can see what's actually happening is it expressing, because genetics, probabilities and propensities, is this actually expressing? And as I told you earlier, and I want people to understand what some of my clients go through. I had one male in his 40s, cholesterol was super high, and he did DNA with me, and he was homozygous and all the ABCG8s. So we did the cholesterol balance test, and he came up through the roof on the.
What's through the roof? It has to be above 30 to meet that.
Yeah,
If it was
at the end of the
22,
red.
that's severe, but that's
Yeah.
not true phytosterolemia.
Yeah, it was pretty high. And he had, I believe he had a history, a family history with this as well. And it took him 3 cardiologists. He said, please give me the Zetia. Please give me the Zetia. It took him 3 cardiologists for someone to listen to him. Now what I do, I will actually type up reports for my clients to take to their physician, because I say, hey, I'm the lifestyle person. I'm not a physician. But here's what I'm seeing in my 7.5 years of genetics. I understand these genes. And so I type everything up for them. And I've had a couple of them refer their people to a cardiologist. The one I was telling you about earlier, a female, the doctor, she was just at the cardiologist last week or the week before. And he said, do you have any heart issues? She said, no. Do you have, is there a heart history in your family? She said, not that I know of. But yet she tested in the red, and she had tested 5 years prior when she found out doing her DNA that she was homozygous for the ABCG8s. And I think she's got ABCG5 in there too with the heterozygous. And so they just told her when she was still in the red, showing the hyperabsorption of the beta sitosterol, that we'll just keep an eye on it.
Yeah, drop the beta. The beta is an irrelevant term. It's a biochemist. Just say sitosterolemia.
Sitosterol. Okay. So she tested high there, and so the doctor said, we'll just watch it. No one watched it for 5 years. So she came back and we went through her genetics again. And I said, you're high risk here. And she said, I tested this years ago, and I saw that. And I said, you need to test again, because she had changed her diet and was also eating more of these plant sterols. And so we tested again, and it was markedly higher over these past 5 years. So her cardiologist was the one saying, I want to see your genetic test because you don't have any symptoms, so nothing's happening. And I said, well, isn't the main symptom looking at the blood work that there is hyperabsorption happening here, and something needs to be looked at?
It gets very complicated. So if you're if you're really, as far as having atherosclerosis, you have to have a high ApoB level, too many particles that are carrying whatever sterols are going to invade your artery wall. But if your ApoB is normal for whatever reason, You could still have excess phytosterols in the blood, but they're not going to cause heart disease in that person. They just get into the cell membranes and cause other pathologies. Now, the majority of people who are hyperabsorbers are going to have an increased ApoB and LDL cholesterol too. So that those are the ones that need treatment. Ezetimibe is your first line therapy for them. Now, if you mention that you tell them to stop eating sterols, that's irrelevant, because even if you're a vegetarian, you eat the number of phytosterols that make it to your gut are very little. So it's you have to have the broken apparatus that's absorbing it. Where you can get into trouble if you're a hyperabsorber is people go out and they buy these phytosterol supplements because they're told you they will lower your LDL cholesterol. So if you're a hyperabsorber, they do displace cholesterol from the gut lumen from being absorbed, but you then even absorb more phytosterols. So phytosterol supplements can worsen any degree of phytosterolemia. So if you're a hyperabsorber of cholesterol, eat all the veggies you want, but under no circumstances listen to the kid in the health food store who tells you, here, I got a package of phytosterol supplements, take them. Never, never, never.
Amen.
And those are the people where you ought to also tell them you probably ought to restrict the cholesterol in your diet. If you're not a hyperabsorber, you can eat whatever cholesterol.
That's what we do. I never tell people, I tell them, like, these are foods that you don't necessarily, you don't want to stop eating. They have the benefits, and it's not going to make a difference. From everything I was taught, stopping the foods doesn't make a difference. And you can't cut every single one of those foods. But there were a lot of them are going to be, like you said, on those supplements, and I've had to pull people off of those sterile supplements.
Yeah, for sure.
Yeah.
Now, you mentioned the Boston Heart Lab, and we'll talk about that in a moment. There's two other labs you can get sterols tested at. One is LabCorp, which is, of course, way more physicians are associated with LabCorp than Boston Heart Labs. Now, you don't get the fancy report that Boston gives you, but the test, how you order in the LabCorp, is you ask for plasma sterols. And you might have to look it up in their online manual. If you call, the clerk answering the phone is not going to know what plasma phytosterols are. But what LabCorp does is they ship them out to the Mayo Clinic, which analyzes them. Now, if you have an affiliation with the Mayo Clinic, you can order plasma sterols from them directly. So those are your three sources. Okay. Now, when you get them back from Boston, Susan mentioned it's called the cholesterol balance test. It's a dumb term. They ought to just call it plasma sterols. Yeah. Now, you do get some sterols that will tell you, are you over-synthesizing or not? And that's fine, because they're very necessary also. But here's how Boston reports them. And when you pick up the report, you're going to see a lot of bar graph colors, red, green, or yellow. Totally ignore them on the Boston Heart Lab. See, Boston reports sterol concentrations via two metrics. And the first, and this is where the colors come from, and they have columns to the right side of the bar graph. You'll see it's the normalized ratio. What they do is they divide your sterol concentration, converted to moles, divide it by total cholesterol, converted to moles, and that's a ratio. And they use that. If it's high, you're a hyperabsorber. If it's low. Now, the problem with that, especially if you're on lipid modulating drugs, which are lowering your total cholesterol, that ratio is erroneous and should not be used. Now, to the right of the column that says the normalized ratio, it says absolute concentrations. That's where you want to zero in. So you will see milligrams per liter of sitosterol and campesterol. And then with the little nomogram I'll give to Susan and she can share online, you will know if you're in the bottom 20th percentile of the absolute concentration, you're a hypoabsorber. If you're in the 80th percentile or above, you're a hyperabsorber. If you're in the 99.9th percentile, you have true homozygous phytosterolemia. If you have something less than the 99.9th percentile, you have severe phytosterolemia. So you have to know what these concentrations are. And Boston does not report the population percentile cut points for the absolute concentrations. It's ridiculous. So you need that. Yeah, now, look, in many cases, the normalized value does correlate with the absolute concentration, fine, but you make all decisions based on the absolute concentration. They might be normal, and you'll see red bars on the left, totally, because something else has changed your total cholesterol. And likewise, you can see green bars, and yet you're a hyperabsorber. So always use the absolute concentrations.
Wow, because now I was new in genetics. I was new to
Mm.
this testing, and I had someone come up with it with the ABCG8s homozygous and an ABCG5 heterozygous, and we tested him, and he was all the way on the left on the green, bottom
Yes,
of the
totally,
green.
totally. You got to look at the absolute concentrations.
I didn't know that at that time,
Yeah.
but
And
he
this,
had the symptoms.
here's why this is true. Because if you order them from the Mayo Clinic, and by the way, the Mayo
Yeah.
Clinic was the first lab in America that really offered phytoster or any sterile testing. Joe McConnell, I worked with him at the Richmond Labs. He was the clinical chemist who invented this testing out there. When they report sterols, they only give you the absolute concentration. They don't give you this cockamamie ratio that has no meaning. And you have to know what Mayo Clinic's population percentile cut points are, but I'll share that with you too if
That would be
you ever
great.
order
That
it
would be
there.
great because
So you just have to
and
look at this is why you could look at that total, that normalized value and think you have a phytosterolemic and you do not. So it's the absolute concentration that is used.
yeah, this is hugely valuable. Now I have to go back through all my people's stuff. And then there's some are symptomatic, some aren't. The most common, like you said, xanthomas. And for people that don't know what xanthomas are, they're little fatty tumors underneath the skin, correct?
Cholesterol tumors
Cholesterol,
underneath the
because
skin.
it's
Yeah.
the buildup of that. Joint pain is another big one that I've
Oh,
had
yeah.
people
Look, when you
report.
get too many phytosterols in your cell membranes, in the skin, it's the buildup of not cholesterol, but phytosterols are in those xanthomas. But if the phytosterols get into your glomerulus, you're going to have protein losing nephropathy. If they get into you, you forget the brain, that's a whole different story. But whatever cell they get into your red blood cells, you will get a hemolytic anemia. So you get into joint cell membranes and the tissues producing the collagen, you'll have dysfunctional joints. So it's a multi-system
Yeah.
disease depending on your level. And remember, if you've inherited that, you've had that from the day you're born. You actually had it in utero. It takes decades to start causing trouble. Now, the true phytosterolemics will often get them in childhood and everything. The lesser degree phytosterolemics, they'll may manifest nothing, or they'll show up with coronary disease or some far lesser renal disorder or borderline anemia or nothing. But phytosterols should not be in your cell membranes. They cause dysfunctional cell membranes. And you can only judge that by you don't want to be above the 80th percentile of any phytosterol.
And one other thing on testing. This was another client. She tested high absorption, and had the symptoms, had family history. Went to a cardiologist that she loved because she had been seeing a cardiologist because her cholesterol, her lipids were so out of whack. But again, they were just testing her basic cholesterol and triglycerides. When I do labs with people, I do the apolipoprotein B, LP little a, which will be next week's topic. Are there, first of all, are there other blood markers that are good basics to start with around lipids, number one? And number two, with testing, this client, her cardiologist did the CAC, so the calcium score on her, and he
Yeah.
said, you have no blockage. So she was like, he said, I'm not giving you Zetia, I'm not doing anything, you're fine.
Yeah, that's
And
again totally
it's,
inappropriate. If you have high levels of a particular lipid in the blood, whether it's giving you coronary disease yet or not is irrelevant. You still are at risk for that disease down the road. So unless
yes.
you're 90 years old, who cares what anything is? But if you're 60, and many 60s make it into the 80s and 90s nowadays, you don't want to be dealing with the pathology. I'm 80 right now. I don't want to have any pathologies in my bodies. And of course, I was testing years ago. I would have picked it up had I had
Yeah.
something like that. So just because you don't have anything detectable as calcium, remember you can
That's where I'm going
have
with this.
non-calcified atherosclerosis, but the calcium score would be zero, but you still have soft plaque in your arteries. So you need a CTA, but very expensive, more expensive test, and usually not used for screening unless somebody can afford $1,000 or $2,000. Whereas the coronary calcium might cost you $150, but that's a
Yeah.
late stage imaging thing with coronary disease. So, look, it's a good test to have. But I've told you these things can be expressed in childhood and adolescence. You're not going to have a positive coronary calcium score if you're a 16-year-old with phytosterolemia. So
Yeah.
you got to know about these tests. And look, if you discover this on any patient and they share the knowledge with their doctor and they tell them to ignore it or don't worry about it, your best bet is seeking out a lipidologist. You can go to the American Board of Clinical Lipidology, or there's a great, it's the Family Heart Foundation. They deal with genetic lipid disorders. So if you contact them and they'll even speak to you, they will hook you up with someone in your area of the country with a specialist who knows what he's talking about. And look, the average doctor, I don't blame. Look, every doctor can't know everything, especially unusual diseases. But hyperabsorption of sterols is hardly unusual. LP little a, which we'll talk about next week, is 20% of humans walking the planet Earth. And hyperabsorption of cholesterol is easily 30, 40% of people walking around. True, phytosterolemics are far less, but even the lesser degrees, the hyperabsorbers of sterols are at risk, and they have to be treated. By the way, the true homozygous with the super high, above 30 milligrams per liter, they actually take 20, 30, 40 milligrams of ezetimibe to control them if needed. Sometimes the 10 milligrams works miracles, but that's the one person you would actually, sometimes if you have to, and only repeat blood tests would show you, push the ezetimibe a little bit.
How often would you, so for my clients that are coming up showing hyperabsorption, and we work with, I work with lifestyle, I try to bring in their physician and say, can you assist here? When would you retest again?
Anytime a lipid therapeutic maneuver, 2 months.
2 months?
6 weeks, 8 weeks, because these things work rapidly. You don't have to wait 2 years. Now, you may have to wait 2 years to see a xanthoma regress or something, but the blood levels change very quickly. So any lipid test, if you're started on a new drug, if a doctor tells you to come back in 6 months, you need another doctor. You need to keep an eye on these things. Once you get them stabilized and normal, then you can infrequently test the blood on them, but
Yeah.
as long as the person remains compliant with the therapeutics that you've outlined. By the way, in your area, if you get an in-between hyperabsorber of cholesterol, other than ezetimibe, now if your ApoB is high, you should go with ezetimibe, but you can try, there is a supplement, not called a phytosterol, it's a phytostanol. Stanol and sterol sounds like, hey, one's got an A, one's got a. So a stanol is a sterol. There's one double bond in the first ring of a cholesterol molecule. If you saturate that, that cholesterol becomes cholestanol. If you take sitosterol and you saturate that, it's cytostenol. You change a sterol into a stanol. Now, why is that important? That Niemann-Pick doesn't recognize stanols at all. It will never absorb them. So if you supplement phytostanols, you will prevent the absorption of both phytosterols and cholesterol. So that's a supplemental way that you could attack phytosterolemia. It's called Benecol. There's one product,
Oh, I've seen that.
phytostanol.
Yeah.
Benecol comes as a spread or a cracker, and you
Yep.
can chew them, and then you do the test and see. The other trick you can try, our gut bacteria have the ability to change sterols into stanols. And if they do that, then no sterol can be absorbed. So if your microflora in the gut get to a phytosterol or cholesterol before it's absorbed, they change it into a stanol and then it cannot be absorbed. And the bacteria that does that under normal circumstances is Lactobacilli reuteri. And there are yogurts with lactobacilli that are supplements that can reduce cholesterol absorption also. So those are a couple tricks that fiber in the diet and stuff like that all reduces absorption of sterols a little bit, not much.
So what, and I'll tell you my thoughts on this, but I would love to hear your thoughts on this. Oh, first of all, let me backtrack because we missed over on it. So for basic lab tests, again, when you're just seeing somebody on an annual basis, or I'm starting with someone coaching, I say, have you had labs in the last year, 6 months? And if you've had a history, I do the deep dive. I like to do the deep dive around cholesterols or around lipids. So what would you say are the
Yeah,
base ones to start
good
with?
question. And the workup to rule out the most common cause that's going to kill humans, atherosclerosis, is you do your standard lipid panel. That's always going to be done. But you do apolipoprotein B, ApoB. And every time you do the lipid panel, you do ApoB because there are some people who LDL cholesterol will look great, but ApoB is high, so they're at high risk. And there are people who have high LDL cholesterol, but ApoB is good, so you can ignore the high LDL cholesterol. All right. Now, in the lipid panel, more and more labs are reporting it, but if they don't, there's a free calculation. You subtract HDL cholesterol from total cholesterol, and that obviously you're taking away the cholesterol you're taking away HDL cholesterol. So what's left is the cholesterol that are in your potentially atherogenic ApoB particles. That is called non-HDL cholesterol. It's the cholesterol that's not in the HDLs. On average, whatever the LDL-C goal of therapy is, non-HDL-C should never be more than 20 or 30 milligrams above the goal. So you want to normalize both non-HDL cholesterol. It's really, if you're looking at non-HDL cholesterol, you don't even have to look at LDL cholesterol because non-HDL cholesterol is a better guesstimate of ApoB. If you are measuring ApoB, you really don't even have to look at either of those. You look, ApoB and triglycerides are really the only lipids you really need. Next week, we'll talk about, though, one time in every person's life, they have to run this Lp(a) test. This is a genetic thing. You've either inherited or you haven't. If you haven't, you're not getting new genes anytime soon. So, but once in a person's life, and it should start really in adolescence. Pediatric guidelines say, hey, kids at 8 and 9 years old need a lipid profile. I don't see no reason not to do an Lp(a) at that age, too. By the time you're age 5, your Lp(a) level is at your adult levels. Why not check it one? And then if the kid doesn't have it, then the kid doesn't ever have to have that test again.
I just think there's so much misinformation out there.
Well, let me give one more test, and then you can
do it.
The other tests we do in 100%, you got to do apolipoprotein E genotyping. Now you got to explain some stuff to the patient, but the other gene other than ABCG5, G8 that's associated with hyperabsorption of cholesterol is ApoE4 alleles. Many people who know E4 or homozygous E4, E4, they have high LDL cholesterol and high ApoB, in large part because they're hyperabsorbers of cholesterol. Not always, but it's high correlation, just like the HDL cholesterol being high is a clue. So you want to know ApoE for two reasons. You have the E4 allele, you're at risk for both heart attacks, but you're also at risk for cognitive impairment. And there are plenty of things we can do for that nowadays if started early in life.
Absolutely. I'm an ApoE 3/4. So that's increased enough for me.
Better than a 4/4.
Yeah. I know, but still that 4 is in there. And I thought, Malbec tastes as good as my wits. I'm 60 now. I see how much cognitive is just so important to me. We don't think about this when we're younger. And I try to get this ground into my people. Saturated fats, but yet you'll hear some experts talk about we put someone on a keto diet and went high saturated fat and that helped their cognitive. But I think it's basically getting them off all the processed crap.
Yeah, but there's one bad thing with that. Ketogenic diets, there's a little data that it may help cognition, but in a large number of people, it sends ApoB and LDL cholesterol through the roof. And if you want to stay on the ketogenic diet, then you should take ApoB lowering therapy with the ketogenic diet. But sometimes that ketogenic diet sends ApoB and LDL cholesterol so high, even lipid modulating drugs you really have to either get off of the saturated fat and use monounsaturated fat and polyunsaturated fat. That'll give you ketosis, but you don't have the saturated fat, which is screwing up your LDL receptors.
And this is what I'm so excited to address with you. I did my own little podcast, I guess a month or two ago on lipids, what I thought to test, and it's everything you're talking about here, and how. So someone would hear, oh, it's plant sterols. See, I told you carnivore is the way to go because plants are the bane of our existence, right? And so they're eating, and I've had clients come to me eating steak and butter and cheese all day. That's all they eat. and the cholesterol's through the roof.
Yeah,
But yet your
ketogenic diet.
functional people and influencers out there saying the higher the cholesterol, the better. We need high cholesterol. And this is one
Yeah,
myth I had Gil debunk, so we won't go too much into it. But these, and what I really harped on in the podcast I did was, if you even consider trying one of these diets and think you're going to stay on this long term, you better look at your genetics, because the people that I see that their cholesterol goes sky high and their doctor's like, oh, it's fine now. We know that high cholesterol is not an issue. But are you are you looking at ApoB? Are you looking, do you know what your ApoE status is? Are you doing these deeper LPA? Are you looking at these different markers and not just your basic cholesterol? Because the information out there is so bad, and it's turning people down really bad roads. And then other genetics,
yeah,
the
terrible.
TCF7L2 with the high saturated fat is higher risk for type 2 diabetes. And I'm seeing carnivore people and keto people with insulin resistance and with prediabetes, and they're going, but I'm going to stay on this because I just have to keep eating more meat, right? The insanity out there, Dr. Dayspring.
Well, listen, the other thing
False
too,
information.
you might feel great, but remember, in about 40% of people, the first symptom of atherosclerosis is goodbye, you drop dead. Or you survive the heart attack, but then it's too late. You already got damaged arteries. That can be helped, but you're sick for the rest of your life. So listen, there's a lot of bad advice out there. I always say, forgive my humor, in America, you're free to be an idiot. There's no law. I can't lock you up, and I can give you the best advice. I can read you my curriculum vitae, which thank God Susan did not. And you might say, geez, you've accomplished a lot of stuff in the lipid world in your life. But I got this internet guy this chiropractor on the internet who's telling me don't worry about cholesterol. So you pick and choose who you want to listen to.
And speaking of a chiropractor, one of my early people that had the ABCG8 homozygous, and she tested as hyperabsorbing, went to her chiropractor, and because I said, go speak to a doctor about Zetia. Look at about, is this something that you're going to need? And so she goes to the chiropractor, and he said, oh, Zetia. And again, he's thinking it's a statin, right?
You don't know.
He had no idea. He said, you cannot go on a statin. You cannot. And I said, it's not a statin, but he had her so petrified that she, as far as I know, she's never done anything about it to address it.
Like I said, you're free to make your own healthcare decision, and you're free to play Russian roulette or not. Do it. But there's enough good source. Would you not trust the American Heart Association, the National Lipid Association, the Endocrine Society, people who really know about lipids? We've got 100 years of research on lipids. It's not like we discovered them last week and we're making all this stuff up. This is solid as science can be. Now we're getting a hell of a lot smarter with our genetics as far as helping us even better ascertain risks. So, my God, and you're going to listen to some nitwit who doesn't know that ezetimibe is not a statin. And as far maybe I'm wrong, but in my chiropractors are never allowed to prescribe medicines anyway. So why would they even want to tell you?
He told her not to go to a doctor, not to go to the doctor because it's too dangerous. Right. There's too many side effects. And from what Appearance Clinic said, they've been using the Zetia on the people that they've been finding with these issues. And they said they really weren't seeing any side effects. It was just positive. And my guy that took the 3 cardiologists to listen to him and get him the Zetia, his numbers dropped. He said within 3 months had dropped in half.
Oh yeah, because you're going to be a hyper responder.
He's fit. And the interesting thing, a year and a half ago, he came back to me and he said, I want to run these tests. I want to do DNA on my kids. One is 9, one's 11. One had, I think it's called Wegman's disease or something that he had also. So another genetic thing. And he said, so I'm just wondering if any of them are lined up for this sterol issue. And one of the daughters was hetero and the other one was just like him, homozygous. Now, what a gift at those young ages to be able to monitor this.
Yes.
That's what I tell people. And I had another one that with a couple, and she was a bigwig obstetrician in the next town over. And she came up heterozygous or homozygous, ABCG8 and one of the ABCG5s. And she had never heard of it. And she said, wow. And she was 33. And she said, I wondered, my cholesterol just shot up out of the blue. And I didn't understand why. And then we tested their 18-month-old. And he came up intermediate risk. He's heterozygous because the dad didn't have any. But again, she said, it's not something I'm going to worry about right now. Going, I might just be this little coach here, but I'm telling you, this is what I want people to understand. This is a big heads up, because if indeed, as you're saying, these tests are showing that there is hyperabsorption here, and God forbid the true, which one are we using, phytosterolemia or xenos?
Everybody's got
I have so
any sterol that's not cholesterol
sterol
has xenosterolemia, and most of them would be phytosterolemia, but they're not the homozygous with the levels above 30. You're not going to see many of them. But all the others are still at intermediate risk due to their hyperabsorption of cholesterol with the phytosterols. And then the phytosterols themselves they affect your retina. I can send you some references that you would start respecting phytosterols being in human bloodstream. Evolution did not give us the ability to synthesize phytosterols for one reason: we're not plants. So they gave us the ability to synthesize and absorb cholesterol. That's the sterol we need, but you don't need too much of it.
I'll tell you what's been super helpful to me with the platform out of Australia, the PH360 I use. They've developed a clinically supervised AI. It's one of the very few, I don't know what other clinically supervised, medically supervised ones that are out there. It's like having a clinician. And when I input this data in that I get from the testing, and I say there's ABCG8s here, homozygous, or ABCG5, whatever, I'm adding in my things. And then when the test results come back from True Health Labs, we put that in there, and it understands the plant sterols. So one actually caught, and I think it was black seed oil, that one of my clients had been taking black seed oil, and it said, not with this testing. This is another one that can amp that up, pull her off of it. So we pulled her off the black seed oil, but it's helping me to catch some of these things that I wouldn't have thought of before.
Yeah, look,
and looking
AI
at this,
is going to help a lot of people with a lot of things.
Yeah, and this one's
even
just,
a layman who gets back their phytosterols or cytosol campestre, just go to AI and ask, what is this? And you'll get and that's why you have to tell your doctor, hey, when you go home tonight, go to whatever AI you use and type in phytosterolemia. And
I do it for them. I type it all up, send it to them, and
it's not hard for a doctor to figure out in today's world. And look, like I said, no doctor can know everything. So if a patient says, I don't know, somebody told me on this blood test I have this, doctor even on his iPhone could, hey Siri, and she would tell him what.
Exactly. Yeah, the one I use is specific to the individual. So that's what I love, because it looks at how they're created and everything. So it's got all these details, and that's where I can get very personalized as far as lifestyle interventions around, like you said, around the lipids, the saturated fat, the different intakes, and make sure we're adding the right things and not having too many of the things that they shouldn't be having and at specific times. And that's where I'm really seeing some changes in dropping ApoB. Really nice drops in short periods of time with ApoB.
Yeah, that's your real goal of therapy.
That's a huge one.
Yeah.
It's a huge one. So,
but you have to know synthesis, absorption. You have to know a lot of things to effectively lower ApoB. So that's the story in a nutshell. I hope we haven't confused too many people. Like I said, you may have to listen to it twice for some of my highly technical scientific talk.
But it has been such an informative for me. And like I said, I've been working with this for a few years now, and this has been so incredibly helpful to me. And I'm going to have my clients with the lipid issues with these things, it's going to be a requirement that they listen to this. And I've been telling them, where do you hear the expert coming on? I want you to listen. I want people to understand, because I don't want to be the person they come to and it's just like they don't learn anything. One of the biggest things I want to do with my clients is help them be their best medical advocate. And the more they understand themselves, how their genetics affect them, and be able to relay this to work with their doctors, or their coach or whatever. The more you understand you and know where these propensities lie, the better decisions you and your doctor are going to make moving forward. And lifestyle plays a big part in anything like this. Like we said, down to, hey, everybody needs to go carnivore. Plants are the evil. I have clients that we put on a higher plant-based due to where they are with insulin, depending on the person. We'll go a little bit higher plants. They might have kidneys, liver, very, very stressed. So we just lower this protein for a little bit, and the number changes are amazing. But these are the people that are told go carnivore, go keto to drop this, and they get worse. Once I look at I go, I know exactly where your genetics are going to come up. And almost every time I knew this was going to happen. You're set up this way because it's just not right for you. And we're also individual. So hopefully that makes sense.
I hope your people listening to you now will better understand this one complicated aspect. Really, once you learn, it's not that tough.
No, it's like I said, you put it down into very understandable ways. It's just a lot of information. Listen to it a couple of times, and it makes so much sense, and it's going to help me in my practice, and I think it's going to help the people listening. And if you have the familial cholesterol, if you've had parents, say your dad died of a heart attack at 40 or 50, and you see these things, your cholesterol is elevated, but you're told it's fine, do the deeper dive. Yep. Do the deeper dive. If you want to test ABCG8, ABCG5, these plant sterols, it is in my food panel. And always has been, and it's not going anywhere in the DNA. And mine is one of the only ones that tests for it that I have seen out there.
Very easy. There you go.
The information is out there, people. Right? I thank you for clearing up some of these falsehoods that are just really hurting people instead of helping. And I think hopefully we'll save a life here. That's what it's about.
All right. So, and we'll talk about that other gene.
We're going to LPA next week. LP-Lillet. So if someone wants to find out more, you're on social media. I know you have a massive presence. Where could they find you? We will also have everything in the show notes. I do a lot of education on, I keep calling it Twitter, but it's X now. Just reached 100,000 followers, and it's all lipids all the time. No politics, hey, it's my birthday next week. My cousin just got married. It's all lipids all the time. And I'm very good at making graphics on lipids to help you understand. So I post a lot of them. Anybody who's in the medical, a clinician of any type, on LinkedIn, I'm just at Thomas Dayspring. You can follow me there, but you have to ask, can I follow you there? On Twitter, you could follow me. You don't need my permission. But on LinkedIn, hey, can I connect with Dr. Dayspring? And for sure, if I see you have some medical credentials, I try and limit it to that. But sometimes if I'll look at your bio on LinkedIn, I'll let it in. Yeah. And whatever I put on Twitter is also shown on LinkedIn too. But I like to limit it to discussion of medical professionals there. What's your Twitter or X handle? Oh, yeah. It's not Thomas Dayspring. It's at Dr. Lipid, DRLIPID. I love it. Thank you so much for shedding light on plant sterol buildup. I am so grateful for this. Like I said, there was a reason God had me wait 2 years. It was for it to be you to come here. I thank Gil for recommending me. Gil's he's fantastic. He's a highly valued colleague, Gil Carvalho, that's for sure. I love really, him. It's Gil. It's not really Gil. Oh, it is. Oh, really? Portuguese, and that's how they pronounce it. It took me about 3 years to learn that, but he doesn't care what you call him. I asked him. Yeah. I said, dude, should I refer to you as Dr. Carvalho or Gil? And he said, Gil is fine. So he didn't correct me. So I'm going to get on him for that. And what I appreciate about talking with people like you and people like him, and why I wanted him on, I had to wait 3 weeks or 3 months he booked ahead of time because he's so busy, was there's no agenda. It's not out here pushing an agenda. Just like I'm not here to sell products. I'm not here to pump myself up. We're here to, like I said, bring on the haters. I don't care. I'm going off on detoxes next week. These detoxes that people are doing, right? All for the almighty dollar. It's about getting real information out there and deciphering what's false. And that's what we did with him. I don't care if people come at me for because I go with what I see in my clinical practice. This is what I see. This is what I experience. And sorry, influencers, you're just off the mark here. And I like to call that
You
out.
do what you do, but you bring in experts to interview to take you to the next level. That's what it's all about. You got to keep
I know
learning.
my limitations. I am right.
All right. So
thank
we'll
you.
see you next week.
You bright and early again. So thank you so much. All right. So everybody, please share this podcast today. I'm telling you, there is someone that you know that is unaware, and a light bulb is going to go off, and we are going to make a difference. So share this podcast today, please. Thank you so much for joining us. Get out there, make it a great day, and be your most authentic self.
Thank you for tuning into my podcast. If you enjoyed this week's episode, I'd love for you to share it with someone who'd find the information useful. Please leave a review anywhere you listen to podcasts, and it'll help the information get out to others. If you're interested in seeing if we're a great fit to work together, the link is in the show notes below, where you can sign up for a free consultation with me. So go make it a great day and let your authentic self shine.